Welcome to this OncLive News Network presentation, broadcasting live from MJH Studios. Today's discussion will be focused on systemic therapy for hereditary breast cancer and evolving treatment strategies in this setting. I'm your host, Dr. Joyce O'Shaughnessy. I'm the Celebrating Women's Chair of Breast Cancer Research at the Baylor University Medical Center, Texas Oncology, and U.S. Oncology in Dallas, Texas. And today I'm joined by two colleagues who are experts in breast cancer treatment and research. Dr. Tiffany Traina, Clinical Director of the Breast Medicine Service, Associate Attending Professor, and Section Head of the Triple Negative Breast Cancer Research Program at Memorial Sloan Kettering Cancer Center, and Associate Professor of Medicine at the Weill Cornell College of Medicine in New York, New York. And Nadine Tung, Associate Professor in the Department of Medicine at Harvard Medical School, Director of both the Breast Medical Oncology Service and of the Cancer Risk and Prevention Program at Beth Israel Deaconess Medical Center in Boston, Massachusetts. And during the next 60 minutes, we're going to navigate through some of the questions surrounding how we treat patients with breast cancer and germline mutations in BRCA1 or 2. And we're going to consider how the availability of PARP inhibitors will change the treatment landscape going forward. So with that, we're going to start by talking about BRCA testing. You know, we've been working hard over the years to remember to try to do germline testing in women who are newly diagnosed with breast cancer, but it hasn't really been so much of an emphasis in the metastatic setting. And now, here we are, because of the availability of olaparib and soon to come other PARP inhibitors, that's in the metastatic setting. So who are we supposed to be treating in the who is supposed to be testing in the metastatic setting for germline BRCA, Nadine?
Exactly. Well, there's a new test to treat criteria put out by NCCN, which states that if a woman has metastatic HER2 negative breast cancer, and would be appropriate for treatment with specifically olaparib, because that's now FDA approved, that germline BRCA testing is appropriate for that patient. It's not entirely clear how many additional BRCA mutations we're going to find compared to the previous NCCN criteria, because that was extremely sensitive for finding BRCA carriers in newly diagnosed or the early setting. But nevertheless, it does allow us to be more permissive in our genetic testing. I don't know that a triple negative breast cancer patient has to be limited to diagnosed age 60 or younger, for example. And I think then one of the questions that really comes up is, do we test women in the initial setting? Do we test them in the metastatic setting? Do we do germline testing? Do we do somatic testing? And I think just a few sort of take-home messages are probably good to remember. I would say that still in the early setting, when a patient is appropriate for germline BRCA testing, they should be tested. It has implications for their surgery, et cetera, and perhaps prophylactic oophorectomy, et cetera. But in the metastatic setting, it can get a little tricky. We're doing a lot of somatic testing to guide our treatment. So I think that some of the principles I would say is that if a somatic BRCA mutation is identified, those patients should be reflexed to germline testing. Most, but not all, of the patients will have a germline BRCA mutation. About 4% will just have a somatic mutation in breast cancer. So positive reflexes to germline. I would say no matter what the somatic tumor testing shows, if that patient meets traditional NCCN criteria for germline testing, do the germline BRCA testing. Sometimes the tumor won't show it, but the patient has the germline mutation. You don't want to miss it. And then the last thing I would say is the VUS. We've really educated our clinicians that a variant of unknown significance should not be treated like a BRCA mutation. And in the germline setting, we don't act on VUS. In the somatic testing, I think it's still evolving. If I were to get a BRCA1 or 2 VUS in my somatic testing, I would check the databases like ClinVar for the germline testing, and if I could prove it was a benign change or a VUS, I would ignore it. But otherwise, I would reflex to germline testing because I don't think the somatic databases are as established or well worked out. Those would be my points.
No, thank you. Thank you. That is terrific, and it's terrific that NCCN now has said that anyone who might be a candidate for olaparib or in the future other PARP inhibitors with HER2 negative disease is eligible for testing. So that really gives us a lot of leeway to do so for these patients, if we can remember to do it, in the metastatic setting, which is sometimes challenging with everything else going on with those patients.